tropical Asia because they usually have the Daffy antigens, the Asians. So the ovale usually thrives in that setting. But in Africa, we lack, or a majority of us lack the Daffy antigens. That's why it's not really common here. It is not uncommon to see co-infections. That's two species of the Plasmodium in a single person. So with this, when this happens, you have the co-infections, and the treatment of that is a little bit, different from that, from the standard. So we talk about the epidemiology of malaria worldwide. Then we zoom in into our country, Ghana. So in 2019, about 229 million people were infected with malaria. And the countries, or the endemic countries, were about 87. Um, about 29 of these endemic countries contributed to 95% of these 229 million of the cases worldwide. And it is pathetic to know that about 51% of these 95% were from Africa, the top five being Nigeria, Congo, Uganda, Mozambique, and Niger. Globally, the deaths associated with malaria has been on a downward decline, which is quite impressive, but I think there's more room for improvement. From 2000 to 2019, over almost a 19-year period, the decline of death associated with malaria has dropped from 736,000 to 409,000. And with these statistics, to about 95% of the deaths associated with malaria were also from endemic countries, from the 87 endemic countries. 51% of this 95% of deaths associated with it were also from the top five countries. That's i.e. Nigeria, Congo, Tanzania, Mozambique, and Burkina Faso. With Ghana, in 2019, we recorded about 6.7 million cases of malaria. And in 2018, these cases were about 11,000 more. So in 2019, we had a decline of 11,000 cases. And the proportion of deaths associated to malaria per thousands, also decreased from 2012 to 2019. That's 10.8 to 1.1, which is quite significant, extremely significant. The transmission of malaria is basically through the female Anopheles mosquito, which accounts for about 90% or more than 90% of it. The rest of the two are rare, or which is not, which don't make a significant proportion. That's fetal-maternal transmission, and also through infected blood products. We'll take a look at the life cycle of the Plasmodium. And this diagram summarizes everything that we will need to know. So when the female Anopheles mosquito comes in contact with any human, it does two things: either to release sporozoites or to take up a gametocyte. So the cycle is in two phases. We have the asexual cycle, which occurs in the host, as in humans, and the sexual cycles, which occurs in the vector, the female Anopheles mosquito. So when it comes in contact with you, let's assuming this mosquito is introducing the sporozoites into the human being. The sporozoites get into circulation and attack the hepatocytes of the liver cells. In the hepatocytes, the sporozoites undergo mitotic replication, or undergo cell division, to form the merozoites. These merozoites are released into the blood circulation, and it undergoes two main um it goes into two main broad categories. Either the merozoites differentiates to form the gametocytes, or the merozoites attack the red blood cells. If the merozoites differentiates to form the gametocytes, the next bite of another mosquito, um, they take up the gametocytes, and the sexual cycle takes place in the mosquito. But if the merozoites affects the red blood cells, they enter the feeding stage of their cycle. That's what we call the trophozoites. The trophozoites is the feeding stage of the Plasmodium species, and it also undergoes replication to form the seasoins. These seasoins are also released, or they rupture the red blood cells and are released into circulation, and the process kicks on. So depending on the species, this is typical of the Plasmodium falciparum. With respect to the ovale and the vivax, in the hepatic phase, some of the merozoites and become dominant, and they form the hypnozoites. And these hypnozoites later cause what we call the relapse malaria. When it comes to the erythrocytic phase, depending on the species too, they have intervals at which they are released into the bloodstream. Usually, the falciparum, the ovale, the vivax are released every second day, or yes, every second day, and that's what we call the Asian malaria. With the malaria, they are released on every third day, and that's what we call the amiquaten malaria. So when the female Anopheles takes up the gametophytes, the sexual cycle takes place in it, where they form to fuse to form the eukaryotes. The eukaryotes and differentiate to form new sporozoites, and the cycle repeats again. So this has already been said in the diagram. So with the classification of malaria based on the severity, we have uncomplicated malaria and we have complicated malaria. So complicated malaria is basically the evidence of malaria in the bloodstream, either a blood film or an RDT, without any life-threatening complication or any end organ damage. And with the severe malaria is presence of malaria in the bloodstream with any end organ damage or life-threatening complication. So with the life-threatening complication, we have two indices under which we put them, and we have the laboratory parameters, and we also have the clinical parameters, under which you can classify the malaria as a complicated or a severe malaria. So the next slide summarizes the criteria for severe malaria. So this diagram looks at the criteria and also the prognosis of the features. So with the clinical features, we have impaired consciousness, we have respiratory distress, we have multiple convulsions, we have frustrations, we have shock, we have edema, we have abnormal bleeding or DIC or jaundice. So if you are certain that any of these parameters, at least one of it, is due to the malaria parasite or the malaria infection, then it is classified as a complicated malaria. And this usually happens frequently or is more common in the pediatric setting, but adults can also get, or patients who are not immune to the malaria parasite. So returnees, pregnant women, people with immunosuppression can also get these clinical features. With the laboratory indices, when the hemoglobin is less than 5, when there's also hypoglycemia, when there's also metabolic acidosis, when there's also renal impairment or hyperparasitemia, any of this can be classified as severe or complicated malaria. So a minimum of one, then you are good to classify the malaria as severe malaria, because the treatment of severe malaria and uncomplicated malaria are quite different, and we'll look at it. So with the clinical features of malaria, the symptoms and the incubation period usually differs based on a couple of factors. That's the host factor, the socioeconomic factor, and the causative species. So patients who are not immune, or patients who don't have, or the immune system are not well built, and for instance, our pediatric population, especially children under 5, our pregnant women, people with comorbidities such as sickle cell anemia, patients that have undergone splenectomy, returnees from non-endemic region, or even patient or people who were even in the endemic region and went to non-endemic region and spent more than 6 months over there. When they come back, we also put them in this party, this group of people, and patients with low social economic status, and the type of species of malaria that's that is causing the malaria. So usually the falciparum tends to be more severe, or more aggressive as compared to the other species. So that you might or you might not have symptoms of malaria. So if you are having the symptoms of malaria, the most common of all of them is the headache, which accounts for about like 90% of it. But the symptoms of malaria are usually non-specific. So they are more of constitutional symptoms that we can all have. We, we can all see on the slide. So headache, malaise, arthrasia, anorexia, cough, and so forth. But headache is the most commonest of all of them. The paroxysm of fever, chills, rigor, sweating also occurs either on the second or third day, depending on the species, as I said earlier on. So the falciparum, the ovale, and the vivax usually have the tertian. That's every 48 hours, and the malaria occurs usually on every third day or every 72 hours. So usually patients who are at risk of the malaria, as I said earlier on, so children under 5, pregnant women, patients with comorbidity factors such as sickle cell, HIV, patients who have undergone splenectomy, and patients with low immunity, as I said, visitors from non-endemic areas. With the examination findings of malaria, it is also non-specific. So when the patient is asymptomatic, I don't think you will find any specific findings on examination. But usually when the patient presents with severe or the complicated form of the malaria, you can have any of the severe or the complications of the malaria. So when the patient comes with cerebral malaria, so you should expect that the patient will have an altered mental status. When the patient presents with severe anemia, the patient will present with pallor, may present with jaundice, may be lethargic and all that. When the patient comes with respiratory distress, you should all expect, when the patient also comes in renal failure. So usually the examination findings of malaria is not quite specific. They may also be hepatomegaly, they may be splenomegaly, so forth. So with the workup of malaria, we'll basically divide it into 2 groups. We have the diagnostic and we have the supportive. So with the diagnostic, the thick and the thin blood film is the gold standard. And the thick blood film is more sensitive than the thin blood film. But the thin blood film helps in speciation. It tells you the different types of species. It can also tell you the stage or the phase of the species. And it can also tell you about the density, the count. They can give you a count of it, of the parasite in the blood. With the polymerase chain reaction, it is by far the most superior investigation, but it's not readily available. because it tells you the speciation, and it can also tell you the parasite count. And it's also extremely sensitive, such that when the parasite count is even um, 10 parasite per microliter, the polymerase chain reaction can pick it up. But with the thick blood film, when the parasite count is below 20 parasite per microliter, it's quite difficult to pick it up. The rapid diagnostic tests can also be used to diagnose malaria, but you can't use it to follow up on the treatment of malaria. The rapid diagnostic test is just a cartridge that contains antibodies. So what it does is that it reacts to the malaria antigen. It reacts to the malaria antigen, and when it is there, it reads it as positive or negative. So the rapid diagnosis test, we have basically two types. We have what I described earlier on, the one that contains the antibody that reacts to the antigen of the malaria, and we have one that also is the LDH type. And by far, the antibody type is more superior than the LDH type, because and that one is more sensitive as compared to the LDH type. But the LDH type can pick up other species such as the ovale and the vivax, but the one for the antibody is basically for falciparum. So when the infection is not of falciparum, it will be difficult to pick it up. So then we also have the microhematocrit centrifugation that can also be used to diagnose malaria, but does not tell you about the speciation. We also have the fluorescent dye or the ultraviolet indicator test that can also pick it up, but does not tell you about the speciation. So basically, with the diagnostic tests, the thin film, the polymerase chain reaction, they usually tell us about the speciation. The rest does not. With the supportive investigation, you would like to do a full blood count and look at your differential. So usually when the patient comes in with severe anemia from your your HB may be low. Thrombocytopenia is also a feature of severe anemia. When you usually see leukocytosis on the full blood counts, it should raise suspicion for the differential diagnosis of malaria. With the liver function tests, usually the cholestatic function and the hepatic function are usually deranged. With the cholestatic function, it is more in the direction of the indirect bilirubin. With the renal function, if the patient is presenting with any acute renal failure or acute renal injury from your malaria, it is also one of the tests that you can use to diagnose it. To monitor the markers of hemolysis, you can do your heptoglobin, your LDH or urine hemoglobinuria, or you can just do your basic urine RE, and you can also pick your hemolysis from there. With the G6PD, you do it one basically. What if the hemolysis is not from the malaria? It can also tell you the differential, maybe G6PD effect. And some of the medications that we put our patients on, these patients with the defects are usually react to it, especially our SP, the SP or the Primaquine. they usually react to it. So you have to know the G6PD status of the patient. With your arterial blood gas, it helps you to diagnose your acidosis, your metabolic acidosis, and the other supportive investigations that you can also do. So as I said, the RDT, we have two basic types. We have the antigen-based. So the antigen-based, it picks up the antigen of the malaria, not the antigen is not in the RDT itself. The RDT contains antibodies of this thing which react to the antigen of the malaria. So that one, as I said, you can use to diagnose your malaria, but not use for treatment, because the antigen stays in the blood for 28 days. So anyone who has had a complete treatment of malaria and it even tests after the treatment during this 28 days period can test positive for RDT. So that's why it's not used as a follow-up. And sometimes too, there also be cross reaction with anti-antibodies, such as the amyloid factor 2. So with the LDH type, what it does is that it looks at the ADH and is also, as I said, can also pick up the other species, such as the vivax, the malaria, and the ovale. So we'll now look at the treatment of malaria. So we'll group it under two, treating the complications. So we'll first start, so with the treatment objectives, what you just want to do is to treat the uncomplicated malaria and to achieve cure so that you prevent progression to severe form of the disease, and also to prevent the spread or the transmission of malaria, and also to also prevent treatment failure or to address treatment failure, and three, to provide a cure for severe malaria and its complications. So the treatments, we will look at it in two phases: treating the uncomplicated malaria and treating the complicated malaria. So we'll start with the uncomplicated malaria. So in all the treatment principles, we have the drugs that we use to treat the malaria, and we have supportive treatments that we will do alongside, yes. So with the treatment of the uncomplicated malaria in Ghana, the medication that we use, the artemisinin-based combination and therapy. So it's basically two group of medication. We have the artemisinin and derivative, and we have the non-artemisinin derivative. So that the artemisinin derivatives are the artesunate, artemether, and the dihydroartemisinin. And the non-artemisinin base, which is basically the chloroquine, the quinines. So we have the amodiaquine, the lumefantrine, and the amipiprazole. So the reason why we are using this particular combination, or the reason why this is our standard, is that one, when you use a double agent, you are able to reduce your rate of resistance. Then two, the double agent gives you a longer half-life of the medication. These double agents are also well tolerable, and these double agents are able to achieve maximum and clearance of the plasmodium from the blood. So that's why we like to use this particular medication, and they also have an additive and synergistic effect. So as I said, so the two drugs, they have the additive and synergistic effect and are able to maintain and therapeutic efficacy with a lower rate of resistance, and they also have a longer duration of action. But with the artemisinin specifically, they are the new drugs, or they are the ones that came to replace the ones that we know, the chloroquine or the quinine. The reason being that is, one, they have a rapid and effective clearance rate of the plasmodium from the blood, and also they're able to affect, or they're able to target the asexual form of the malaria parasite, whether in the gametocyte phase or in the Season's phase of it. And they're also well tolerated too, in addition. So with the uncomplicated malaria, let's go back. So the first line in Ghana is the artesunate amodiaquine or the artemether lumefantrine. And the second line is the dihydroartemisinin and piperaquine. So those are the things. So we don't use the quinine again for treatment of uncomplicated malaria in Ghana. So this cuts across whether the patient is pregnant or not. So, but with the pregnant women, we advise that with the first trimester, we try to avoid this medication. So with the first trimester, for them, we give room for the use of the quinine with our clindamycin. But if the patient is not able to tolerate the quinine or the clindamycin, you can still go ahead with the artemisinin-based combination, even in the first trimester. With the severe malaria, we have basically two groups of medication. That's the artemisinin-based derivative and the chinchona alkaloids, that's the quinine. So the first line of the medication for the severe malaria, we have the IV artesunate. If you're not able to get IV access, you can use IM artesunate. And the second line is the IM artesunate, because the artesunate is not given as IV. Then if you don't have the artesunate, you don't have the artemeter, and the only one that you have is the quinine, then you can start with your IV quinine. If you are not able to get your IV line or difficult in accessing IV line, then you can do your IM quinine. So this is the same for pregnant women. You follow this for severe malaria. With the IV artesunate, there's a rule of thumb for all the IV medications for the severe malaria. At least you should do a minimum of 24 hours before you switch to your oral when the patient can tolerate. So with the IV artesunates, you start with a loading, or you start with a dose of 2.5 milligram per kg or 3 milligram per kg. If the patient's weight is less than 20 kg, you go with the 3 milligram per kg. But if it's more than 20 kg, you do the 2.5 milligram per kg, and you do it at 0, 12, and 24 hours. You switch when you complete this 24-hour course and the patient can tolerate oral, then you switch him to your artemisinin-based this in combination. Either oral artesunate amodiaquine, artemether lumefantrine, or the dihydroartemisinin. That's what you can do. Any one of them, you switch them to it. But if the patient is not able to tolerate orals after completing these 24 hours, you can do a daily dose of it for a maximum of 7 days before you switch him to the oral. With the IM artemeter, you start with a loading dose of 3.2 milligram per body weight. Then you do your maintenance dose of 1.6 milligram per body weight for a maximum of 5 days. And if the patient is able to tolerate oral at any listing after your 24 hours, then you can switch him to your oral. So you can also switch him to your artemisinin-based combination therapy. With the quinine, we advise that you start with the IV, but if it's difficult getting the IV access, you can also do the IM. So the quinine, you start with a loading dose of 20 milligram per body weight. To the maximum you can give for it is 1.2 grams. Then if the patient is not able to tolerate orals after your loading dose, then you can do a maintenance of 10 milligrams per body weight. That's 8 hourly for the first 48 hours. Then after 48 hours, you can space it up. So 10 milligram, that one you now do it 12 hourly for a 7 days duration. The reason why you are doing that is because of the side effects that is associated with quinine, and we'll look at them. Most of them is the hypoglycemia that we come along, but we also have other side effects associated with quinine. And if the person is able to tolerate the oral, you also switch him to the artemisinin-based combination for the patient. As I said, oral quinine has no place for it unless you are doing it for a patient or for a pregnant woman in the first trimester for the uncomplicated. And even with this, when you are treating for severe malaria in a pregnant woman and you start with any of them, you switch him to the oral artemisinin-based combination. So these are some of the side effects. The commonest of all of them is the hypoglycemia, but they can also have the chinchonism, that is the tinnitus or the hearing problem associated with it. But you can also have nausea. The patient can be restless, tremors, and the cardiovascular issues associated with it, the arrhythmogenic properties of quinine. It's rare. This table looks at the viral availability, why artesunate is superior to the others, and why the route of administration is also important. So with artesunate, artemether, and quinine, we'll look at the IV routes. When a dose of artesunate is given through the IV route, the onset of action is from 1 to 2 minutes. So averagely 1.5 minutes. 5 minutes, the action of onset begins for IV artesunate, as compared to quinine, which takes about 4 hours. But IV artemether is not given via IV routes. You should take note of that. But when artesunate is given via the IM route, it takes less than an hour to take effect. But with IM artemether, it takes a minimum of 6 hours. And with IV IM quinine, it takes less than 4 hours to take action. And as I said, the reason why the artemisinin are far, far superior to quinine is because of one, the high activity and low resistance, and to the double action of it. So it both affects the gametocytes and the schizoids in addition. So these are the artemisinin-based combination that are recommended in Ghana. So as we've rightly said, so when you complete your IV medications for the severe malaria and you are switching the patient to oral, as I said, there's no room for quinine. I'm sorry, this is a typo error. Even in the pregnant women, we don't have any room for IV for the oral quinine. So you switch him to the first line of medication, that's artesunate amodiaquine or artemether lumefantrine. If the patient is not tolerating it well, then you now switch him to the dihydroartemisinin ampere dihydroartemisinin piperaquine. Sorry, so this is an oversight. When you are switching a pregnant woman to the oral, you switch him to the artemisinin-based combination therapy. So we'll look at some of the complications and we'll try to see, we'll go through quickly some of them, the management of some of the complications. So with the complications of malaria, it is quite devastating. And you could have cerebral malaria, you could have pulmonary edema, metabolic acidosis, acute renal failure, and DIC, hypoglycemia, severe anemia, and hypovolemia or shock. So with the supportive treatment of malaria, that's with the complications of malaria, and let's try and assess the consciousness level of the patient. And usually let's use the appropriate scale, the Coma scale. Usually we have the pediatric and Glasgow Coma scale, and we have the adult one. So we are using it. Let's be careful. And we can't also overemphasize that the vital signs are really important in a chronically ill or an acutely ill patient. So at least within the few hours, especially the first 2 hours, let's try and monitor our vitals more frequently. And when the patient becomes more stable, then we can now move on to the 2 hourly or 4 hourly vitals monitoring. The blood glucose, usually because since hypoglycemia is a complication of it, so it's important that we correct the hypoglycemia. So any blood glucose level less than 2.2, or if you don't even have a strips to check, you just assume hypoglycemia and just manage, especially in the pediatric setting. Then when the hypoglycemia is managed, then you can put the patient on a dextrose-containing infusion so that the patient doesn't run into hypoglycemia. You can also pass your NG tube to also avoid hypoglycemia through, feeding. But if the patient has, pulmonary edema from either over fluid or maybe from the complication of the malaria, it's one of the indications that we stop the IV fluids and we do the oral or the enteral feeding. So managing an unconscious child or managing an unconscious patient, at least there are some basic things that we all need to do. At least the close monitoring of the vitals is really, really important. And even if the facility has an ICU care, it's important to send the patient there to at least manage the patient, an unconscious patient, so that they'll have a close monitoring of the vitals. And also monitoring the consciousness level of the patient for at least a minimum of 6 hours will help. But if you can't do that, at least a minimum of 12 hours will suffice. Then we should note that patients who are unconscious are prone to bed sores. So you can either use the report bed for that patient, but if the patient can't afford or the facility don't have the report beds, we can at least do a minimum of 2 hours bed. The patient should be 10 in bed every 2 hours. Then also an NG tube can be passed for the patient either for feeding or to prevent aspiration. So when we do all this and you still see that the patient condition is not improving, then we need to reevaluate the patient. We need to go back and take and look at our history and our examination closely and ask, are we really managing the patient, or the patient has other differentials aside malaria? When we're able to do that and confirm that still that they are managing the patient for malaria, or what we are managing, we are certain that it's malaria and it's malaria that is causing the patient to be in this particular state, then we can also look at the drug administration. Are we underdosing the child, the patient? Or even if you are giving the right doses, is it given at the right time? And are we doing everything well? So we'll also look at the term recurrent malaria, which comprises of recrudescence or treatment failure, reinfection or relapse. So recrudescence and reinfection talks more of the duration. If the patient has treatment failure, it's usually pertaining or it's usually for uncomplicated malaria. You want the patient to have a full course of the rights and regimen, and compliance wasn't an issue. And it also happened within the 28 days duration or within 4 hours week. So when you are treating a patient for an uncomplicated malaria, and you are certain that compliance wasn't an issue, and you are certain that you really gave the patient the right combination of medication, and within 24 hours, the patient still tested positive for malaria with the blood film comment, not with RDT, but with the blood film comment, then you can diagnose the person of treatment failure, and you now move to the second line of medication. That is, if you are using IV, if you are using oral artesunate amodiaquine, you can then switch the patient to artemether lumefantrine, because this particular type of malaria is the same phenotype of the species that you are still dealing with. But with the reinfection, when you've treated the person of the uncomplicated malaria, and after 28 days, the patient presents with signs and symptoms of malaria, and you did your blood film comments, and there were malaria parasites, then this patient has been reinfected with malaria, and you now start him afresh from the first line this thing of medication. So you don't treat him as a treatment failure, but you start again. You start the patient as if he has now had a new infection, or he has now had the infection and you're starting the medication. So you start him with any of the first line medication. Even if the patient had treatment for malaria before the 28 days or before the 4 weeks, you can still start with the same medication. With the relapse is more peculiar to the ovale and the vivax species. As I said, when the merozoites are in the liver, some of them differentiate into hypnozoites, and these are usually the dormant phase of the merozoites. Sometimes they can go into reactivation and cause, the malaria, which is normally termed as relapse malaria. So with them, you have to confirm one that the species that you are treating is the vivax or ovale. So in addition to your standard treatment, you just have to add um, the drug that you need to add is the mefloquine turret for the relapse malaria. So with the treatment failure, as I rightly said, is for uncomplicated malaria. Patient are taking the right dosage and the right regimen of the drug, and still the patient still has the asexual form of the parasitemia in his blood within 28 hours or within 4 weeks of starting treatment. And this could be due to either the patient wasn't tolerating the drug well, such that he was vomiting it, or it could be the drug of poor quality, or maybe there could also be resistance or recrudescence to it. And this is also common with the Falciparum species. So with the recommendation for it, assuming you started the patient with oral artesunate and vodacin, you can move on to artemether lumefantrine. Or assuming you started a patient with artemether lumefantrine, you can move on to artesunate and vodacin. So those are the first line. So any one of them. If the patient is not tolerating any of your medications, then you can now move on to your second line of medication. That's the dihydroartemisinin pyrimethamine. But if the blood smear comes back negative, then we have to reevaluate the patient for the cause of the fever or whatever he's presenting with. So with the prevention of malaria, it's basically into 5 main groups. So your environment, to prevent mosquitoes from biting you, and also to boost the patient's immune system or to give him medications that will be in therapeutic dose, such that when he gets infection, it doesn't cause the malaria. Or you take away the vector from the environment, or you boost the person's immune system. So with the environment, we have to make sure that our environment is clean. We don't create breeding grounds for mosquitoes in the environment. So stagnant waters and all those things. And we also advise to sleep in the long-lasting treated insecticide mosquito nets to prevent mosquito bites too. And we are also advised that at least when we are outside, we wear protective clothing so that we don't expose our bodies to mosquitoes. And with the chemoprophylaxis, there are medications that we use, and there are various medications that can be used. But the chemoprophylaxis are basically for a group of patients. One, the non-immune visitors, patients from non-endemic zone, or patients who were in endemic zone and moved to non-endemic zone for more than 6 months. We consider them to be non-immune patients. And children also under 5 years. We also have this seasonal malaria prevention this drugs we normally give to them too. Usually during the peak periods of malaria, that's when we normally give it to them. And also in our pregnant women, so there are medications that we give to them usually after 16 weeks that we call the SP, the sulfadoxine pyrimethamine that we also give to them. This is to prevent malaria. But sometimes these chemoprophylactic agents are not 100% effective, and they are usually breakthrough malaria. So when the patient is diagnosed of malaria on his chemoprophylactic, you have to stop him, assess him, investigate him, and when the malaria is confirmed, you treat. There's also this residual spraying that is usually done. Either you do it personally, that's the indoor residual spraying that you do for yourself. So you through your insecticides that you do, or there are usually companies and NGOs that also do it on and this on in the community. Then there's also malaria vaccine, which is also on the pilot program that is currently in Sunyani, that's the Sunyani municipality of Brownhafo. So as I rightly said, the chemoprophylactics are not 100% effective, and they are usually sometimes they are breakthrough in malaria. So for patients, for the non-immune people coming to the endemic region, we advise that the anti-malaria medication for the prophylactics should be started between 2 to 14 days before arriving in the malaria endemic zone, and should also be continued 1 to 4 weeks after leaving the endemic zone. And these are a couple of medications that you can use: the mefloquine, the doxycycline, the proguanil, the atovaquone proguanil combination. You can also use it. So as I said, sometimes there are breakthrough malarias, and usually you have to stop the medication and do the treatment for the malaria. So with prevention in pregnant women too, as I said, is the medication of choice is the sulfadoxine pyrimethamine that is usually given after 16 weeks, and a minimum of 3 doses is given 1 month apart, and it's usually under a direct observed therapy. So usually the pregnant women take it in front of the midwives. So as I rightly said, the seasonal malaria chemo prevention for children under 5 years, so between 3 months to 5 years, we give them this medication to prevent um, malaria. And the medication of choice in this part of the world or in our countries, amodiaquine plus sulfadoxine pyrimethamine for these children. Thank you. And these are my references.
Great. Thank you, Dr. Jawula, for the excellent presentation. I think you covered virtually everything, right from diagnosis, clinical history, to prevention and chemoprophylaxis, as well as the vaccines for malaria. So like I indicated, those of us on the platform, if you could kindly type in your questions, your comments, your suggestions, you could do that in the chat box. There are already a couple of questions there which we would address shortly. And then at the end of that session, if we still have time, then we could ask you to unmute yourself and go ahead with your comments, contributions, and then questions as well. So the first question is from Charles. He asks, is the artesunate injection having a maximum dose? Dr. Jawula, can you address that?
All right. Thank you very much, Charles. So as I rightly said, the artesunate is given based on the weight. So if you are more than 20 kilograms or if you are less than 20 kilograms, it doesn't have a maximum this thing at all. So whatever calculation you do and you get, that's the dose you give for the patient. So if the patient is less than 20 kg, you do the 3 milligram per kg. And if the patient is more than 20 kg, you do the 3 milligram per kg too for the patient. Thank you very much.
Great. So just to highlight the fact that sometimes we underdose people, and like Dr. Jawula rightly said, we need to calculate using the weight of the person. Of course, adult, we are in adult medicine, but our colleagues at pediatrics, we usually weigh the children, and many of them who usually fall below the 20, they would rather do the 3 mg per kilogram body weight. And those of us who are more than the 20 kg will look at the 2.4. And it's important that we take note of this so that we don't underdiagnose or under-administer, the dosage. Because like you saw in this presentation, the details were, and the reason for use of the artesunate is for the rapid clearance of the hyperparasitemia. And like we did say, even if you come in and clinically you don't have any of the symptoms pointing out to a target organ damage from malaria, or even a clinical complication of the malaria, which will then classify you as complicated or severe malaria. But by way of your parasite density, hyperparasitemia alone is one of the laboratory parameters that he did put in. So if as soon as possible, ASAP, we will need to clear this parasite load. The only way to go is to go by way of the artesunate. And of course, that's one of the reasons the WHO did move from quinine to artesunate, because of the rapid clearance of the parasites from the system. And of course, if you give the right dose, you would be able to clear that shortly. So great, Dr. Jawula. The diagnosis, second question, the diagnosis of malaria seems a bit curious. You talk about uncomplicated, not simple malaria, and then severe, not complicated malaria. Any reasoning to this? So why we rather prefer to say uncomplicated malaria, severe malaria? Any reasoning to this? Or both are correct? That is simple or uncomplicated malaria on one hand, or severe or complicated malaria on the other hand. I think that has worked in from Charles.
All right, thank you, Charles. So we want to shun the simple malaria because malaria is not that simple. So that's why we move to the term uncomplicated malaria. So malaria can progress from uncomplicated to the complicated form. And the severe and uncomplicated malaria can be used interchangeably, but WHO, when you look on all their this, they like the complicated form. So complicated malaria, uncomplicated malaria, that's what WHO likes. But to say malaria being simple, no. But with the complicated and uncomplicated, with the complicated or severe malaria, you can use them interchangeably. Thank you.
Fantastic. The third question from Charles as well was, I've seen cases where the lab results were negative for malaria parasites. That is, malaria parasites not seen. And yet the clients recovered from ill health from malaria drugs. My question is it by chance or the lab failed to pick up the parasites?
Charles, if you don't have evidence of malaria, please don't treat. You should widen your scope, especially in this part of the region or in this part of the world where infection is so common and so distant. So you should have to widen your scope. So usually when your clinical suspicion of malaria is very high, we don't exclude malaria with a negative RDT or with a negative result from a BF for NPs. So that's it. So you have to do it on 3 consecutive times. So you do it day 0, day 1, and also day 3. So you can do and 3 tests on day 0. That's 0 hours, 6 hours, 8, 12 hours, and 24 hours. If it's still negative, you are still having a suspicion of it, then you can repeat it on the 2nd and 3rd day. But if you do all this and it's negative, another person can have a look at it. But for you to treat malaria without you having your confirmation, it's not part of the guidelines. You have to have the evidence before you treat. So you have to have a positive result before treating for malaria. So as you said that you give the malaria and the medication and the patient. You can also give any medication and the patient would have also been well. Maybe it could have been a viral infection that's had or like the patient recovered from it successfully. So there were other causes of the fever that we think would have been not only malaria. So when as I said, the symptoms and the signs of malaria are constitutional, and any febrile illness could give rise to any one of them. So we advise that you test, and when the test is positive, that's when you treat for malaria. Thank you.
Great, thank you, Dr. Jawula. It's test and treat, is that not it? And it's scientific evidence. It needs to be backed. So if your RDT is negative, your BF for MPs is negative, you have the room of repeating it like he did mention. And of course, if you have a clinically, you think you've excluded other causes of the fever or the current presentation, and you think that the person has malaria, you are allowed to start presumptively on treatment. But once there's laboratory evidence available that is not malaria, after the sequence in which you repeat them all negative, is definitely unlikely that it may be malaria. Several things can come in for this, and more especially with the anti-malaria medicines. We need to be careful because the truth is that they are not only used in treating malaria. So like the advent of COVID has opened us up to know that, look, anti-malarials are used in several other, especially viral infections, because they do have some bit of antiviral activity. So like you see, when COVID came, hydroxychloroquine became more expensive, became prime. But even back in the days, people knew that hydroxychloroquine has some antiviral properties. And so it may, like Dr. Jawula mentioned, it may have been a viral infection, possibly, that you gave your chloroquine, or your quinine-based treatment, which did resolve either by itself or by the antiviral activity of these anti-malaria treatment that you did give. So we just need to be clinical about it and be guided by the guidelines. But obviously, we can't hold you, especially looking at the practice in the rural area and all of that. But if you know that the lab is capable, let them do their work. And if it's negative, it is negative. Fourth question from Charles was, when a client vomits the medication, what do you do?
So on to, and Charles, vomiting, as I said, is a symptom of the malaria. How bad is the vomiting? Is it an intractable vomiting? Then if it's an intractable vomiting, you have to do your IVs. So until the patient is able to tolerate the oral. But it's not any vomiting that at least one or two vomiting. At least the patient can start his oral medication. But if it's an intractable one, you have to do straight IV until the patient is able to tolerate it. Thank you very much.
Great. So obviously, it also depends on the time that the person vomited after taking the medication, as well, whether it's repeated vomiting like you did mention, and where next we go from there. So we have another one from Salam Abdul Kader. He's asking, thanks for the presentation, Senior. How many hours after IV artesunate can one start the oral AL? I think you addressed that, but just for emphasis, maybe you can.
All right, Salam. As I said, all the IV medications have to be completed for a minimum of 24 hours. So after 24 hours, the patient can tolerate orals. You switch the patient to orals. It's not only IV artesunate, even IM artemether and this, and even the IV quinine if you want to use it. But a minimum of 24 hours. If the patient is able to tolerate orals, then you switch.
Great. His second question was, any comment on quinine causing bleeding in early pregnancy? This is on the background of it being recommended treatment over AL in early size. So I'm sure he's asking why we are giving quinine if really it does have any role in causing bleeding in early pregnancy. Obviously, if it does, why then are we using it in the first trimester?
So, Salam, for the quinine, that's one of the effects. It's not only quinine, even the artemisinin-based combination too, they also have this bleeding in early sizes. But as I said, the quinine is used only in first trimesters. And even you are allowed to use the artemisinin-based combination if the patient is reacting to the quinine or the patient is not tolerating well with the quinine. But the quinine is the first line for the first trimester for uncomplicated malaria. But if it was to be a complicated malaria, you treated the patient, they are switching him to the oral. It is the guidelines that we should do the artemisinin-based combination.
Great. Yeah, so I think from the studies that were done in early pregnancy, the bleeding was negligible. And weighing head on head, the benefit versus the risk was minimal. And I say that's why they encourage the use of the quinine in the first trimester. But even right from all trimesters, now if it's severe malaria, really the way to go, like Dr. Jawula said, is the IV artesunate, whether first, second, third trimester, any of the trimesters, IV artesunate. For severe malaria. What you did mention was regards uncomplicated malaria in pregnancy, where then you are allowed to do quinine with clindamycin. I think a lot of us do forget about the clindamycin, so we end up giving just quinine. It is still a dual treatment, quinine plus clindamycin, uncomplicated. And remember that the duration for that, for the quinine, would definitely be 7 days. So it makes it quite a bit difficult. Of course, the alternative would still be the artemisinin combinational therapy. But the first line for simple malaria in the first trimester of pregnancy is the quinine plus the clindamycin. His third question was about the role of mannitol in management of cerebral malaria, any place of its use.
Mannitol has no place in the management of cerebral malaria because the cause of the cerebral malaria is due to the hyperparasitemia of the malaria, or is due to the malaria, and it's not due to any increase in intracranial pressure. So we would rather shun or avoid the use of mannitol in cerebral malaria.
Excellent. Is it advisable to be on anti-malaria drugs together with iron 3 maltose and multivitamin? That's from Sani.
So yes, we have a room for the two. If the patient is spiking temperature, we advise that you don't use the iron 2 polymaltose. If the patient's temperature has settled, then there's a room for the combination of the two. Of course, as you said, anemia is one of the complications of it. So when you've done everything and patient has settled and all those things, the temperature has settled, you can use the two.
Great. So the comment on that is usually, of course, once you are talking about what do you call those one? Hematinics, yes. Iron 3 maltose, ferrous sulfate, all those ones, plus multivitamin. You are talking about mild to moderate anemia, SANI. Obviously, if it's severe malaria, you're looking at hemotransfusion. Okay. And for a mild to moderate anemia with malaria, obviously, your prime importance is to clear the parasites. Obviously, once, like Dr. Jawula said, once this has ensued and you have control of the parasites, of course, there's no contraindication to use of hematinics in the setting of malaria that is complicated by mild to moderate anemia. Then he asks, why is sickle cell trait and G6PD patients have a protective factor against malaria?
All right, thank you very much. With the sickle cell traits, not with our G6PD. Usually the sickle cell traits, what they normally do is that, because the asexual form of the parasite, that's the lesions, they are in the red blood cell. And this particular type of blood cells have shorter duration, or their lifespan is very short. So they usually lies, and by that time, the parasite wouldn't have had full maturation. So because of that, they have this protective destiny. But when they also get the malaria, they also become very worse. They can also progress to the very severe form of the malaria. But patients with G6PD, they're really overstressed. So the stress or the oxidative stress of the parasite alone can tip them into the severe form of the malaria. So that's with respect to the sickle cell traits and the G6PD.
Great. So obviously, although because of the fact that the red blood cells will sickle and the low oxygen tension, and of course the malaria does, the Plasmodium species does like increase oxygen. Once they get infected, two ways: either because of the low oxygen tension, the parasites will not thrive, or the spleen will even pick up the deformed red blood cells and break them down. So obviously, they may not be able to manifest it earlier. But like Dr. Jawula rightly said, then you don't go about saying that you are resistant to malaria or any of that and wear loose clothing after 6 p.m. and all of that. So we are usually quick to counsel all sickle cell disease patients that you need to prevent yourself from getting malaria, because in actual fact, once you get it, really it can tip you into any of the crises, whether it's vaso-occlusive crisis, acute chest syndrome, even to strokes and all of that. So really, that's the way to go. They need to observe all the preventive measures, either the IRS, indoor residual spraying, either the IPT when they are pregnant, or even the ITN, insecticide-treated bed nets, and all of that. So it's extremely important. Yeah, I think we have exhausted all the questions in the chat box, and we've also gone past the time, which we're supposed to have done 4 p.m. I just see that someone has put up something. I was not clear with the vomiting answer. If I give oral medicine and vomit after 5 minutes, what should I do? I repeat it or not? Kindly repeat it if it's after 5 minutes, because obviously the medicine wouldn't have gone in or wouldn't have been absorbed. Of course, Dr. Jawula did add an important part of it, that once there's intractable vomiting, if you keep giving and the person is vomiting, it's not rocket science. We just need to change it to a parenteral form. When the vomiting subsides, like we did see in this presentation, then we'll need to convert to the oral medication to complete the therapy. And that's another thing that we really need to take very good note of, because a lot of people, after the parenteral treatment, especially if the person is on IV artesunate, let's say for about four days, mind you, after the first 24 hours, like we did see from this presentation, each one will be a daily dosing. So people then do about 3 additional days of once daily dosing of artesunate, and they don't complete it with the combinational therapy, either artemether, lumefantrine, artesunate, amodiaquine, or dihydroartemisinin, piperaquine. And then they this puts you at risk of developing treatment failure, or what is otherwise called recrudescence. So we need to be extremely careful about some of these things that we do, because it's not a standard practice. So with the vomiting, the answer is after 5 minutes, obviously, you need to repeat it. If the vomiting is continued, we may have to be evaluated clinically, so that then we can switch to a parenteral form of treatment. I think that's the last question. So we want to thank Dr. Jawula so much. I see Dr. Nabil's hand is up. If you do have we've gone past the time, but of course we would allow for some comments. If you do, kindly put up your hand and then we can do that. Dr. Nabil, I've asked you to unmute yourself and then go ahead, please.
Okay, thank you very much, boss. Good afternoon to the presenter, Dr. Jawula, and to everyone else. I think it was a very, very good presentation. I learned a lot. Congrats, Dr. Jawula, for the very educative presentation. I just want to make a few observations. So one has to do with the issue of the labs reporting no MPC when we send investigations to them. You know, unfortunately, it is the bitter truth, but unfortunately, sometimes our colleagues in the laboratory setting are not fair to us. So there are instances where the prescriber or the clinician would request for both the RDT and microscopy. You know, and after RDT is done and it's negative, they report the microscopy as no MPC. You know, so it's one of the things that we have to guard against. So that if the doctor requests for microscopy should be done irrespective of the RDT report. And so you may have, and we know microscopy is the gold standard. So we've got situations where the microscopy report is no MPC. Meanwhile, it was not actually done. Okay, and they only report it as such based on the RDT result. And this practice is not acceptable. So sometimes it may account for some of the observations we make in our setting. And I think it is something that we need to encourage to be stopped in our laboratory. When microscopy is requested, it doesn't even take much to do the microscopy. No matter how tedious it might be, the lab guy should ensure that they actually run the microscopy instead of relying on the RDT to report for microscopy. That is not acceptable. And that can, like I said, that can explain some of the observations, some of the questionnaires we're alluding to. And then the issue of quinine in first trimester in pregnancy. You see, I want the questioner to know, the participant who asked the question about quinine, the risk of bleeding or the risk of abortion, you know, from the malaria itself is higher than even from use of quinine. You know, so the malaria itself puts the woman at risk of first trimester abortions. Most of the abortions we see are due to the malaria, not even the use of the medication. You know, so it is better to use the drug, like Dr. Akatiba mentioned, quinine and clindamycin first trimester for uncompleted malaria. You are safer. Okay, you don't treat the malaria, you put the lady at risk of abortion. And then one thing I would want to mention is also the presence of gram-negative sepsis. In cases of severe malaria. Okay, it's a very important thing we need to think about, especially those of us practicing in rural Ghana, where we see a lot of severe malaria cases. Most of them, especially the children, most of them invariably come with gram-negative sepsis. Unfortunately, we do not have the resources to run blood culture very quickly, to run labs like procalcitonin that can help you determine the presence of bacterial infection. If we had those resources, it would be easy, to determine whether or not there's infection as well. But most of these cases of severe malaria come with gram-negative sepsis. So we always have to bear that at the back of our mind, especially when temperature is not falling as expected. In malaria, for instance, we expect temperature to fall by crisis. So if you're not observing that, if the clinical picture of the patient is not improving rapidly as expected, one thing about malaria is usually, no matter how bad the patient is, they usually improve rapidly. The improvement is so significant. So let's not shy away from using the antibiotic, especially in the very, very sick patients, in children, when there's that suspicion of gram-negative sepsis. If somebody comes with severe malaria, white cell count is high, think of gram-negative sepsis. So it's something we should always bear in mind. I think these are the observations I want to make. Once again, very good presentation by Dr. Jawula. Excellent work done, and we're very, very educated. Thank you, Dr. Akat.
Thank you, Dr. Nabil. Great. You always bring a lot of great points to make the discussion rich. I'm particularly happy that you brought up something that we failed to mention. That's the gram-negative sepsis. Very, very important. Very important. Thanks a lot. Dr. Abdul Salam, kindly go ahead with your suggestion, your comment.
Okay.
From me, yeah. All right.
Boss, thank you very much. Yeah, boss, mine is more of a follow-up and not really a question, but actually a passing comment. With the cause of the cerebral malaria cerebral malaria, from my outlook and what I know, though I mean you are the seniors, you may help me with that. You know that it's not only the cause is actually not well understood, and parasitemia is actually just, let me say, a fraction of it. Because I've seen other people suggesting maybe cerebral edema as a cause, and that was the premise for my question of hypertonic solution. I don't know if you have any add-on on that. Thank you very much.
Great.
Dr. Katiba, if
Nabil,
I can be allowed to maybe say something small with regards to the question. So, Dr. Abdul Salam, like the presenter mentioned, there's no place for use of mannitol in cases of severe malaria. Even though cerebral edema is part of the it's part of the pathophysiology in cerebral malaria, but there are so many types of cerebral edema. We have a cytotoxic edema, vasogenic, and so on and so forth. Remember that these cases of cerebral malaria may have other complications as well. Some of them may even have an AKI. You use mannitol in such patients, you are going to worsen their condition. Some of them may even come with some respiratory difficulty. You use mannitol in them, you may worsen their cause. Mannitol, the presence of AKI can cause pulmonary edema. So the way to go is to treat the malaria. You treat the malaria, they'll get better. Okay, let's not worry too much about what's going on in the brain in such situations. Once you've been able to make a diagnosis of cerebral malaria, you start your IV assessment, they'll do very well. Okay, and it's only in a few situations that they come out with some neurological sequelae. Most of them recover fully. So let's avoid using mannitol in such situations. I mean, there's no room for mannitol in the management of cerebral malaria. You do your IV assessment, you do your supportive care with IV fluids and so on and so forth. If you suspect gram-negative sepsis, you add your antibiotics and they'll be fine. Okay. Yeah.
Great.
Thank you both.
Yeah. So like we had initially brought in, we need to be really careful about that in that set, even the diagnosis of cerebral malaria itself, really, because like we did here, usually when it comes to severe malaria, really the comorbidities that weigh the person down may not even just be with regards to the malaria parasite itself, but about the other things that have come out, multiple things. And so if we are not careful about looking at whether this is just cerebral malaria, which of course is more or less like a diagnosis of exclusion anyway, the gram-negative sepsis that we did talk about, which in itself can cause a lot of issues, the AKIs and all of that. So in actual fact, the cornerstone, like we said, once you have proved that it's malaria, let's cut the tree from its roots. And then as for the ancillary things like reducing the edema, which is one of the suggested pathophysiology, which can even compound or make the cerebral malaria fatal, it's better we getting down to tackle the parasitemia and clear it off. All right, that's my add-on to it. Any other comments, questions? I don't see any hand up. All right, thanks. So thank you, Dr. Jawula, once again for this excellent presentation. It's been a very good one. All of us have been educated in one way or the other. And next week we would be talking about a topic that is dear to my heart in the rural setting, enteric fever and its diagnosis. Come learn why you should not do WIDA. And if you even ever want to do a WIDA, how you are supposed to go about doing it and all of that. And why you should not treat people based on WIDA. He's treated on ciprofloxacin for virtually the rest of his life because the WIDA keeps coming 1/320, 1/160. So let's make a date with Dr. Excellent as he gives us an excellent presentation on Thursday, same time, same place as always. As we sign off, we say take good care of yourself and please don't request for WIDA unless you really don't know what you're about. God bless. Bye-bye.